to the place where we are gonna talk specifically about some pathology, and we're moving into a look at coronary artery disease and myocardial infarction. So we want to start by thinking about factors that determine myocardial oxygen demand and myocardial oxygen supply. So myocardial oxygen demand is something that we're going to see increasing when we have a heart that's overworking. So probably the leading cause of increase in myocardial oxygen demand is coronary artery disease, because as coronary artery disease gets more and more progressed, the cardiac muscle is not going to receive enough oxygen to meet the demand, right? Because of the narrowed vessels, which is what we're going to talk a whole bunch more about. So the demand on the heart is high, and the ability to meet that demand or supply the heart with more oxygen is limited. And so we'll talk a little bit more about that. So here's a picture of a heart. This one over here is normal, and then over here, I think we've seen this picture before, is a grossly enlarged heart. So that heart is going to have a huge, it has a lot working against it, right? The demand placed on that heart is huge because, first of all, the chambers are super enlarged, so the afterload is huge. The muscle's going to be weak, so the contracting's not going to be very effective. And the demand on that thing, right? The muscle is going to need, myocardium is going to need a lot of oxygen, and most likely it's not going to get it. So myocardial oxygen demand is determined by, first, how much muscle mass there is. So in a hypertrophied heart like the one we just saw, that's going to increase demand. How much work the heart actually has to do, which is essentially saying what the cardiac output situation is like. So the more work the heart has to do, the more demand. So if we have a situation where we have an increased heart rate and or an increased contractile force, it's gonna put more demand on the heart. And so remember, cardiac output we talked about earlier stays steady, right? Cardiac output is a variable that doesn't change until things get really bad. And the reason why it doesn't change is because we have some play, right? We can adjust the heart rate, or we can adjust the force of contraction. We can adjust the stroke volume, and that will consequently affect cardiac output. But all of those adjustments or all of those compensations come at a cost, and the cost is a higher demand on the heart. So that is something that we think a lot about. And then I said just a moment ago, the wall tension situation, right? The larger the radius of the ventricle, the more tension the heart has to generate in order to eject the blood, or the higher the afterload. And same with arterial pressure. The more work the more force the heart has to generate to work against that sustained increase in arterial pressure, the higher the afterload. So all of these things are easy to attribute. We can attribute all of these things, I should say, to an increased work placed on the heart or increased demand. So what about supply? So myocardial oxygen supply, what we're thinking about here is the blood that's being delivered to the heart itself, right? And so, of course, the coronary arteries are the vessels that deliver blood to the heart itself. And with other arteries in the body, the amount of blood flow through the coronaries is dependent on a few different hemodynamic factors. Blood pressure is, of the factors, blood pressure is probably the most important. So when systolic blood pressure falls, the quantity of blood flowing to the coronaries is diminished. And this can occur suddenly, like in cases like shock. where you need, to immediately restore the blood pressure in order to, reestablish an adequate oxygen supply to the myocardium, as well as a bunch of other tissues. Other things that can affect myocardial oxygen supply are going to be changes in blood volume, like in cases of hemorrhage, or in situations where we might have a reduced oxygen content in the blood, like, for example, anemia. And then, of course, where we have narrowing of the coronary arteries, which is probably the most common, and that also is going to decrease supply. So when we think about the coronary arteries, we want to think about, well, when we talk about blood flow or fluid flow in general anywhere, we say that, well, the best way to increase fluid flow is to vasodilate, right? That's the analogy of like sucking water through a fat tube versus a cocktail straw. It's a lot easier to suck water through a regular sized straw than it is a cocktail straw. And it's because of the radius of the straw, right? The larger the radius of the tube, the less resistant to flow. So so we'll see consequently an increase in fluid flow. But the coronary arteries really are not able to exponentially dilate, right? Healthy coronary arteries can vasodilate, and they can increase and consequently increase blood flow about 4 to 5 times. But that's the key to that statement, is healthy vessels. So when we have healthy vessels and we have an increase in demand, our only option to increase supply is to vasodilate, right? Because unlike other tissues of the body, the myocardium under resting conditions removes pretty much the maximal amount of oxygen from the blood, even when it's at rest. So the only way to get more oxygen delivered is to be able to vasodilate. So when we have a lack of blood flow to tissue, of course, we call that ischemia. So if we have a situation where we can't vasodilate because the vessels are narrowed, or there's plaque stuck in them, or they're hardened, all of these things kind of start and they continue in the progress until we have more and more narrowing and less blood flow, and then consequently ischemic damage. If you have vessels that are diseased, that increase of 4 to 5 times, the increase of flow of 4 to 5 times is off the table, right? That doesn't work. So let's look at a couple pictures of some diseased vessels. So these are the same vessels, just using different stain, different preparation on the slide. So what we're seeing, so first, just look at the shape of the tube. Whoops, I pressed a button, I didn't mean to. Just look at the shape of the tube. One thing we know about blood flowing through vessels is the endothelium, we want it to be smooth. We want it to be free of any abnormalities or irregularities. And though you want the lumen to be nice and uniform. And so in this case, those criteria aren't being matched. It's getting worse in this case, right? So this is all plaque. This is getting to be a more and more complex plaque. And what you're seeing in there basically is macrophages stuffed full of cholesterol. We call those foam cells. They get in there, and then we get some calcification. And we get destruction of the inner wall, and then ultimately that destruction continues deeper into the tube. Less and less uniformity to the tube itself. So here we have, again, this is all a plaque. All of this is the patent part. You can see it looks a little bit different in each of those different stains. Even worse, right? So this is a super complex plaque, and we'll talk about what that means in just a minute. But less and less blood flow, you can see, until we finally end up with, on this side, you can't even really see the patent part of the vessel, but on here you can kind of see it, and that's the opened. So that vessel is, 95% occluded, or in that neighborhood. So it's easy to understand. And so that process is a progression, right? And as the vessels become more and more diseased, we have less and less blood being delivered. And it gets even more, probably even a bigger issue is that as the vessel becomes more and more irregular, you have an increasing likelihood of actually a clot forming because the blood is flowing turbulently through that tube rather than in that laminar type of flow. And in those situations, and when the blood flows turbulently, it's much more likely we're much more likely to form a clot, right? The platelets all bang up against one another, red blood cells bang up against one another because you've kind of got this eddy current happening in there, and that will initiate the formation of a clot. And then that clot will continue to float down, and if it finds an area that's even more narrowed, which is likely in this kind of disease, then that clot gets wedged in that tube and no blood gets through. And so what seems to be most likely with these sudden major myocardial infarctions is just that the plaque is very unstable, and what most likely has happened is a clot is generated, and that clot completely occludes the vessel very suddenly. And that can happen when the vessel is, it doesn't have to be 99% occluded, right? It just has to be irregular, which is not uncommon. All right, so we're going to talk some more about this coronary arterial disease, or coronary atherosclerosis. So we'll use the term atherosclerosis in a few different places in this unit. And atherosclerosis in and of itself is referring to damage and narrowing to any arterial. And when we put coronary in front of it, we're talking specifically about the coronary circulatory system, but we could see this happen in any arterial anywhere in the body. But right now we're going to focus on the coronary. And of course, coronary, so this, in the sort of the overarching term for this would be coronary artery disease. And we do know for sure that coronary artery disease is the major cause of myocardial ischemia and likely myocardial infarction. So this would be, I think, by almost every list you could find, we would say that this is one of the leading causes of mortality in the United States. A defining characteristic of coronary artery disease is going to be narrowing or occlusion of one or more coronary arteries. And as we get more and more into it, we can see that the narrowing can result in symptoms, and the symptoms are, the most classic symptom is that of angina pectoris, which does not always have to be present, but it is oftentimes present. And this also oftentimes leads to myocardial infarction or a heart attack. All right, so let's look at how this disease process sort of gets initiated and the progression histologically. And then we'll talk about the major reasons for rapid clinical progression, the main one I just actually discussed with the clot situation. All right, so the most common etiology of coronary artery disease in adults, and actually we're seeing this more and more in children, is atherosclerosis. And basically it's the presence of plaquing. And a plaque is going to initiate in the intima and then the intermedia of the vessels. So basically the plaque is going to most likely develop progressively over time. And over time, it's going to produce different degrees of intravascular narrowing that will ultimately result in partial or complete blockage of the vessel. So how this kind of looks histologically, and this part I don't really care that you get too hung up on, but it's good to sort of have an idea. So it's going to start with just fat in the intima, and then the fat is going to sort of get more incorporated into the vessel, so it will go deeper. So the intima is the innermost lining of the vessel, and then we'll go into the intermedia. So basically what happens is that if that's all that there, if all that's there, pardon me, is lipid, then that's not that big of a deal. That doesn't, the presence of the lipid doesn't indicate any narrowing. It doesn't mean the vessel's narrow or even irregular at that point. They oftentimes refer to that as just a fatty streak. And you can see evidence of fatty streaks in all sorts of people, right? If you happen to be looking, if you're doing autopsies and and cardiovascular disease wasn't the cause of death, you would see evidence of fatty streaks, and you can find data to support this in all sorts of people, starting with kids. We see it more and more now. It's just that, there's no way to really to see it unless you have access to the vessels. And that's not something that we generally have, especially in young people. But then as it gets more progressed, we're going to start to see more evidence of this plaquing. And so what ultimately will happen is fibrous tissue will encapsulate the lesion. So basically the lipid's going to get laid down, and more and more evidence is pointing towards inflammation being a big player in this. And so one of the reasons why that is the case is because the way that lipid gets deposited in that inner vessel is by macrophages. So macrophages are white blood cells, as you all know, and they are phagocytes, and their job is to, basically be sort of monitoring for anything that's not supposed to be there, or anything that's abnormal or in the wrong place or whatnot. So macrophages, which are monocytes, and then they become macrophages, right? So if they're in the blood, they're monocytes. If they're in the tissue fluid, they're macrophages. But they really seem to have a affinity for lipid. And so basically what they'll do is they'll gobble up excess lipid or cholesterol, and they will kind of start digging their way into the inner lining of the blood vessels. So as they do that, they get a new name, and they get renamed foam cells. And so essentially what happens is they kind of get more and more incorporated into the vessel. And so the vessel becomes more and more irregular, and then a fibrous tissue will encapsulate it. Remember, we talked about that. The body sort of does that as a way to contain something that might be, not beneficial. In this case, this is not a beneficial reaction. And then as the plaques become more and more complex, we're going to start to see, some collagen. Oftentimes calcium salts will deposit, other cellular debris, capillary buds, all sorts of things start happening in this plaque, which we saw in those pictures. And then you see increasingly more degenerative changes to the arterial wall. Interestingly, these early stages of damage really are asymptomatic, or they're in that sort of subclinical setting. We historically won't see symptoms elicited until you've got about 75% occlusion of a vessel. And even in those cases, you don't always see symptoms elicited. So what is it that can potentially bring on a rapid progression of atherosclerosis? So if something caused the plaque to enlarge very quickly, probably that's not as common. I mean, it's not impossible, but it's not as common. More likely, because the plaque is so unstable, and there's so much going on there, that's more likely that a person actually bleeds into the plaque. And remember, that tissue, it's a destructive process in the vessel, so it's not uncommon to imagine that would, or not difficult to imagine how you might bleed into that plaque. And then, of course, the platelets are going to stick, and you're going to get a clot, and then that clot is going to completely block a vessel. So that would be sudden. You could go from like 75 or 80% occluded to 100% occluded with a clot very easily. And then another thing that's also a possibility is that the coronary arteries can actually spasm. And some people are more prone to coronary arterial spasms. There's a particular type of angina that's referred to as vasospastic angina, or it used to be called Prinzmetal's angina. And Prinzmetal's or vasospastic angina is due to sudden spasms, kind of unpredictable spasms of coronary arteries, I should say. And the vessels don't even need to have any plaque in them, right? If there is plaque, that would be, even more problematic, but they don't have to have plaque. And why this happens is kind of unknown, and it's very unpredictable. And the symptom presentation, if are symptoms, they are real erratic. Like, they don't show up in a way that's consistent with the way angina generally shows up. Normally when people have angina, the symptoms are elicited when they're under stress or there's some kind of an increase in demand. But that's not necessarily the case with coronary arterial spasm. It can be completely unpredictable, unrelated to either rest or activity. So as I said, inflammation, I think there's some pretty good evidence, and I'll give you some citations if you're interested in this when we meet in class that show that this relationship between inflammation and coronary artery disease and really cardiovascular disease on the whole is something we need to pay more attention to. So to that end, they are doing more testing for kind of standard testing for inflammation. And one test that's being utilized with a lot higher degree of frequency is something called a high sensitivity C-reactive protein, or HSCRP. You can just do a C-reactive protein, or you can do the high sensitivity C-reactive protein. For a coronary artery disease, the high sensitivity C-reactive protein is the one that's preferred. And again, it's kind of a general test, but it does give you a degree of, it will tell you the degree of inflammation. And it seems to be this, along with hemoglobin A1C, these two seem to be very strong indicators of disease processes down the pike. So that would be something to kind of think about. We'll talk more about that one later. So this is a vessel with really ugly plaquing, right? You can see how this vessel is a mess, right? This is all of this is plaque. This is all irregular. The blood flow through that vessel is going to be really significantly inhibited, and they're really likely in this case to either hemorrhage into the plaque or just through a clot just by the nature of the turbulent blood flow. That's fat lipid deposited in a vessel. This is a bifurcation of a vessel here, but this is also lipid deposited in a vessel. This is the descending aorta just as it splits into the renal arteries, and all of this is lipid. There's a whole bunch of lipid in that vessel. And look at this, so you can see all the lipid and the narrowing, right? That's a significantly diseased aorta, and that's a big vessel. All right, really quickly, I want to go over some risk factors for coronary atherosclerotic disease or coronary artery disease. And we'll divide them into the non-modifiable and the modifiable. And I think there's some overlay here that we could maybe argue, or at least I'd like to argue we might switch a little bit. So historically intrinsic is also intrinsic risk factors would also be under the non-modifiable, things you can't really do much about. Your age, increasing age increases risk. Males are more likely to have coronary artery disease than women, but that's getting much more closely matched. Family history definitely plays a role. So we're talking about like first degree relative with a history of early history of myocardial infarction. So that would be something that you would want to be paying attention to, especially if they have a heart attack early in life. If we're looking at myocardial infarctions in like the 40s and the 50s, that's something to pay attention to. Race plays a role. And then inflammatory tendencies. I don't know that I would, now with what we know about genetics, you can get kind of like, that's a rabbit hole that you can get easily lost in. And we don't know enough at this point to really, I'm sorry, that's spelled wrong there. There should be a D. We don't have enough information to draw conclusive, to conclusively determine, one gene, one disease kind of a thing. But we definitely know that we can see some correlations. with some genetic markers. And I will, again, in our class, I'm going to give you a little bit, I'm going to share a little bit of research with you on that. And there definitely are some genes that increase risk of familial hypercholesterolemia, pardon me, and ultimately coronary artery disease. So there are some things to kind of have on the horizon. And again, you would kind of, I think you would use all this other information as well. Like you would start to think about this more strongly in people who have a strong family history. And then you might take that extra step to look at their genetics, if that's something that you're interested in doing or knowing. And I think that there's definitely some utility around that. And we can definitely modify inflammation in the body. So like where, it's, yes, some people seem to be like pro-inflammatory, but there are modifiable steps that can minimize somebody's inflammatory tendencies. So the modifiable factors or extrinsic factors, some things that we can pay attention to are elevated serum lipids. That, again, was kind of what we were just sort of looking at, but that's definitely modifiable. The verdict's kind of out in terms of the role serum lipids play in coronary artery disease. I think it's not quite that straightforward. They definitely play a role, but I don't think it's that straightforward. I think there's other parts of this, like someone's inflammatory tendencies, for example, that definitely need to be considered together. The evidence doesn't seem to point to a direct correlation between an increased serum lipid and atherosclerosis or myocardial infarction. We've thought that, and that's kind of what we've all been taught, but it doesn't seem to be playing as significant of a role. I'm not at all saying it doesn't play a role. It just seems to be more complicated than that. And obviously, because heart disease is still, coronary artery disease is still at the top of the list, and we've been using statin drugs to lower serum lipids very effectively for a pretty long time now, and we still haven't gotten a lot of traction on this. So that tells us, that in and of itself tells us that this is more complicated than that. I'm not at all saying that it doesn't play a role, but it's not the end all be all, I don't think. But it's very definitely modifiable. Hypertension, very definitely important and modifiable. Smoking, we've said this before, and if you don't know this already, smoking is not good for you. There is no good reason to be a smoker. There's lots of bad reasons, and one of the main reasons to not be a smoker is the risk to vascular disease, both coronary artery disease and diabetes. So it increases your risk for cardiovascular disease, diabetes, cancer, all three of those, significantly. So that is a behavior that we would like to encourage people to not participate in, or if they are participating in, to stop, especially if they have coronary artery disease or hypertension or diabetes. Impaired glucose tolerance. This is a big player, major player. This kind of feeds right into inflammation, which feeds right into coronary artery disease. So those are definitely things on our radar that we want to modify it by whatever means that appropriate for that particular person. And then, this kind of historically we put this in minor, but I personally don't. I would keep this major. I don't think I agree that this is a minor. These sedentary life, stress, and personality type. I just read an article, and I'll have to get you the citation because it was pretty interesting, on sedentary life. And the authors were sort of kitschy in their description of being sedentary. And they basically said, being sedentary is the new smoking. Like, it's really not good for us. And for lots of reasons, but it is definitely negatively affects the cardiovascular system, makes us more, less, we see impaired glucose tolerance, more inflammation, all sorts of metrics are affected by the sedentary lifestyle. Stress very definitely plays a role in inflammation, and then the personality type kind of goes along with that. So that's, in a nutshell, some of the major risk factors for both modifiable and non-modifiable for coronary atherosclerosis. So in this lipid conversation, just really quickly, these are sort of the classic recommendations for serum lipids. So when we historically measure serum lipids, we measure VLDL, HDL, LDL, and total cholesterol. HDL is what we would sort of classically consider the good one, high density lipoprotein. It has more protein, less triglyceride, less cholesterol, so it's very dense. We want that number to be up, ideally above 45, or I should say it should be over 45 milligrams per deciliter. Ideally, you want it up even above 60 would be better. It should comprise of 25% of the total cholesterol. LDL cholesterol, my brain froze up for a second. LDL cholesterol that's higher than 160 milligrams per deciliter is considered high risk. LDL cholesterol below 130 milligrams per deciliter is considered desirable. And if somebody is in a really high risk group, you might want to see that LDL cholesterol even lower, like around 100 milligrams per deciliter. Here's kind of a visual on this whole cholesterol situation. So we've got HDL, LDL, and VLDL on this picture, and you can kind of see when you look over at the graphic. In the graphic, purple represents protein, yellow represents cholesterol, that kind of pinkish color represents phospholipid, and the green represents triglycerides. So you can see HDL has the lowest amount of triglyceride. It has the highest amount of phospholipid. It has a moderate amount, 20% of, not the lowest because the VLDL has lower, 20% is cholesterol, and then the vast majority, between 45 and 50% of the particle, is actually protein. So these are considered the high density lipoproteins. These are the ones that we want to be up above 60 ideally. HDL cholesterol will increase with exercise. The jury's kind of out with alcohol, but the benefit that we get in terms of cardiovascular benefit with alcohol seems to be this. Moderate alcohol, and we're talking like 2 to 3 glasses of wine probably a week. There's lots of conflicting data around the alcohol picture. I don't know that I would say, I wouldn't ever say, start drinking to decrease your cardiovascular risk, but I would say that a moderate amount of alcohol is probably not going to be a big deal. LDL cholesterol will decrease with smoking and diabetes. So we want to increase that. There's a lot of other foods that will increase LDL cholesterol. If you're interested, you can ask me and I'd be happy to tell you. HDL cholesterol. Now, LDL cholesterol contains 2/3 of the body's overall cholesterol. So the liver is going to remove as much cholesterol as it can metabolize, but whatever is in excess then has to be processed peripherally, and that's where the LDL cholesterol comes in. So again, the LDL cholesterol, when we were talking about macrophages wanting to eat up lipid, what they want to eat up is these LDL particles. So they really like these LDL particles. Again, there's more to this picture, and I might talk about this a little bit if we have time in our class. They're starting to do a little bit more comprehensive look at the lipids because the whole HDL, LDL, VLDL doesn't seem to be enough. And so you can look at subfractions of LDL cholesterol. You can look at the types of particles, small versus dense. You can look at, different types of LDL cholesterol, and some of them are more problematic and they increase someone's cardiovascular risk more than others. And in that same vein, some of them are more susceptible to, or more resistant, I guess I could say, more resistant to being lowered by drugs, whereas where other LDL subfractions are more likely to be decreased with some of the statin drugs and others. So not all LDL, what I'm trying to say, I guess, is not all LDL particles will be able to be lowered with the statin drugs. And unless you're actually looking at the types of LDL cholesterol that's there, you don't really know what you're working with. And so we don't know for sure that the overall number of LDL will definitely come down with statins in the neighborhood of between like 30 to 40%. So it looks very dramatic, but like I said earlier, it doesn't seem to translate into less mortality. So that means that there's more to the picture. And so that's where they're doing some pretty interesting work around this. And there's some labs like the Cleveland Clinic and the Boston Heart Lab and others, even LabCorp and Quest, run some more comprehensive lipid panels, which give you a lot more detailed information about what really is going on with the cholesterol. And I personally think those are great tests. That's great information to have if you're at high risk or you have a strong family history. So anyway, we can talk more about that if that's something you're interested in. And then finally, the VLDLs are chiefly the triglycerides, which are made by the liver to transport fats that are already in the body. And so you can look at those guys. Those ones have the most triglyceride, which I just said, they're mostly triglyceride, and then not a whole bunch of protein. And again, these are really shuttlers. They're just going to be transporting fats around. They're sort of fat shuttles and they're made by the liver. All right. And they're also, when we talk about fat being a good fuel source, this is what we're talking about, these VLDLs. They get stored they get burned for fuel, long-term, nice energy yield, and then they can get stored as fat. All right, the last thing I guess I want to talk about in this video, because I know it's getting pretty long, is metabolic syndrome, which was historically referred to as Syndrome X, but we've dropped that, and now we just call it metabolic syndrome. And the numbers are going up. As of when I looked for the actual percentage of the U.S. population affected by metabolic syndrome, and it's been a little while since I've actually gotten an updated number, but I think a year or two ago they were predicting that at that time they were saying that about 25% of the U.S. population has this syndrome, and I know that the number was expected to increase to closer to 50% by I think the year 2025. I'll have to look at that exactly. So metabolic syndrome, this is not a disease, right? It's a syndrome. So it's like a constellation of symptoms. And what we see with metabolic syndrome is obesity. And not all these criteria have to be met, but this one has to be met, abdominal obesity. And that is defined as 40-inch girth in males or 35 inches in females. And then they have to hit 2 of these other factors. So a high blood pressure, and this is not that high, that's still considered pre-hypertensive. And it's 130 over 85 millimeters of mercury, high blood glucose greater than 100 milligrams per deciliter fasting, which is not, the diagnosis of diabetes is made at 125 historically. High triglycerides, trigs over 150 milligrams per deciliter, and low HDL, below 40 in men and 50 in women. So the first criteria, the abdominal obesity, must be met, and then 2 of the others also will. So if you have 3 of those 5, one of which is abdominal obesity, you meet the criteria for the diagnosis of metabolic syndrome. And we know that there's a lot of people that meet that criteria. Okay, I'm going to cut this here, and I will come back to discuss with you the progression of cardiac ischemia and move into myocardial infarction.